Thank you very much. I will just share our experience at Singapore General Hospital on adopting MIH, or minimally invasive hepatectomy. I have the following disclosures from the various laparoscopic companies. Here, as we know, the history of laparoscopic liver surgery started in 1992 when the first resection was done. And over the past 20 years, especially over the last decade, there's been a rapid adoption of this approach, with more than 10,000 cases over the last 20 years. So why laparoscopic or minimally invasive hepatectomy, MIH? We know from numerous evidence to date that there's decreased wound pain, early convalescence, shorter hospital stay, less blood loss, and most importantly, oncologic outcomes are the same. And what's the major obstacle? As we know, the vast majority of hepatectomies even today are still done open. And this is because we know the procedure is technically demanding with a steep learning curve. Up to 10 to 30% of cases result in open conversion. And there are a lot of questions still on the safety of this procedure, especially during the learning phase. As one of the pioneers of laparoscopic liver surgery once said, laparoscopic liver surgery transfers the pain from the patient to the surgeon. So the aim of our study primarily was to study the evolution of MIH in our first 400 cases at our center. And the secondary objective was to determine predictive factors and outcomes of open conversion. So this is a retrospective review of our prospective database in our academic institution. We do about 200 liver resections per annum. And from 2006 to 2017, there were 400 cases. Of note, 90% of cases were performed only from 2012. We stratified the study group into 4 equal groups of 100 patients. Our results. So this chart just shows the evolution of MIH in our center. So most of the cases, as you can see, are done only from 2012. The type of resections, about 20% were major, and we included right anterior and right posterior sectionectomies as a form of laparoscopic major hepatectomy. 95% of cases were done totally laparoscopically, including 24 which were robotic assisted. And the vast majority of cases, 80%, were for malignancies, of which most were for hepatocellular carcinoma. This table just shows a brief summary of the basic demographics of the patient. About a third of patients had previous abdominal surgery. About 6% had a re-resection of the liver, and 80% were malignant. 8.5% of patients had other surgery. We are not including cholecystectomy, but things like colectomy or bile duct resections. 22% had major resection. And if you look, classify according to the Strasbourg classification, 47 cases or 12% had major hepatectomies. 5% had multiple resections. 40% had tumors in the difficult locations. A third of patients had cirrhosis, and the conversion rate was 9.5%. Median operating time was about 4 hours. About 18% of patients had blood transfusion, and about a third of patients required a Pringle maneuver. The average length of stay was about 4 days, 17% post-op morbidity, and major morbidity occurred in about 5% of patients. 2% of patients had a reoperation. In terms of mortality, there were 2 30-day and 4 in-hospital mortalities, about 1%. So next, we look at the trend or changes of MIH over time. So when looking at the 4 groups of 100 patients, we found that over time, the patients who were older, we started to adopt more and more pure laparoscopy. Over the last 100 cases, all cases are pure laparoscopic or robotic. There were more patients with previous abdominal surgery, more re-resections, and patients at a higher ASA score. In terms of the type of tumors, the rate of malignancy was the same. Concomitant surgery rate was the same, but there were more major resections, more multiple resections, and the conversion rate actually decreased from 17% in the first 100 cases to 6% in the latest. Of note, the operation time actually increased due to the increased complexity of procedures. In terms of other outcomes, there was more use of the Pringle maneuver, although when it was applied, the duration was shorter. The rest of the perioperative outcomes, such as morbidity, mortality, and reoperations, were the same. So in summary, well, basically over time, we operated on older, sicker patients with more complex resections, which resulted in longer operation time, but a decrease in open conversion rate and no change in perioperative outcomes. Next, we look at the predictors and outcomes of open conversion. So there were about 10% of open conversions, and the main reason, as we know, is usually bleeding. So looking at the factors predictive of open conversion, what we found was that the only predictor of open conversion was the presence of liver cirrhosis and experience. When patients had cirrhosis, the conversion rate was 15% versus 7%, and whereas in the first 100 cases, the conversion rate was 17%, and the next 300 cases was 7%. What happens after conversion? When the patients had conversion, not unexpectedly, there was an increased transfusion rate, increased blood loss, and longer hospital stay. Of note, post-op morbidity, reoperation rate, and even mortality was higher in the open conversion group. On multivariate analysis, both institution experience and cirrhosis remain significant. If you look at detail of the in-hospital mortalities, all 4 patients had liver cirrhosis. 3 were related to intraoperative blood loss, including the 2 open conversions, but 1 was uncompleted surgery, which developed nosocomial pneumonia. So, cirrhosis and experience were independent predictors of open conversion in our study, and open conversion resulted in poorer perioperative outcomes. So of note, MIH can be adopted safely, but caution should be applied, especially during the early experience when operating on patients with cirrhosis. So finally, in conclusion, over time, the case volume and proportion of MIH performed increased rapidly. Indications of MIH expanded in our institution to include older, sicker patients and more complex hepatectomies. Operation time took longer, but there was a decrease in open conversion rate. And there was no change in other perioperative outcomes. Institution experience and cirrhosis were independent predictors of open conversion. And open conversion was not unexpectedly associated with increased blood loss, morbidity, and mortality. Thank you.